Hi, everyone, and welcome to our webinar today with Dr. Megan Riehl, who is a GI psychologist with expertise in psychogastroenterology and the management of GI conditions. She is the clinical director of the GI Behavioral Health Program at the University of Michigan and an expert in the delivery of brain-gut behavioral therapies. Dr. Riehl's research and clinical expertise have led to numerous peer-reviewed publications, book chapters, and invited commentaries. And her latest achievement in a very long list of achievements is co-authoring the book Mind Your Gut alongside author Kate Scarlatta. Dr. Riehl has also launched the Gut Health podcast, expanding the conversation on gut wellness to a global audience. And we're very lucky to also have Dr. Riehl as a clinical advisor to the Nerva program. So without further ado, I will pass it off to you, Megan. Thank you so much for being here.
It's my pleasure. I'm very excited. I've been monitoring the chat over here. So hello to everybody. And thank you for taking the time to spend the next hour with us today, where I'm really going to hopefully introduce you to some concepts that you're familiar with and get a little deeper into them, but also talk about how we are working to expand access to brain-gut behavioral therapies, and Nerva is one of those solutions. So when we look at my objectives here, probably those that are attending today recognize the complexity of IBS, but just how multifactorial it is, and how access to appropriate comprehensive care can still be very limited and challenging for patients. We're going to talk about the brain-gut connection and why behavioral therapies are so impactful in a diagnosis like irritable bowel syndrome. I'm going to talk a little bit about gut-directed hypnotherapy and some of the other evidence-based psychological interventions that can be very helpful for IBS management, and really from that team approach in identifying which interventions are most appropriate for patients with IBS. So I like to start with a patient journey that can feel very familiar, and the reality that IBS is a very prevalent diagnosis. There are probably some of our attendees today that are both providers and patients living with IBS. So, it starts with Dr. Smith, who says to Jill, guess what? Your biopsies are negative. Imaging, labs, your colonoscopy, all normal, within normal limits, benign, unremarkable. These are things that our patients hear. It's just IBS. And you can use that medication as needed. And the patient says over here, you've got to be kidding me. I've seen 6 different doctors. I still feel terrible. Nobody understands the impact of this on my quality of life. Something must be missing. I cannot live with these symptoms for the rest of my life. And so we can see that there's kind of this push and pull of the physician having a diagnosis and the patient not knowing really or not really feeling like there's a good roadmap for how they're going to manage that diagnosis. And in survey studies, we've looked at the patient population of those with IBS, and it was found that most patients living with IBS would give up 10 to 15 years of their life for an instant cure. Another kind of staggering statistic is that patients with IBS, again in a survey study, would take a hypothetical medication that would cure IBS, even if it had a 1% risk of death. So this is a complex diagnosis, and this is one that has a profound level of impact on a patient's quality of life. And therefore, one of the reasons why a lot of times physician-only care is just not enough. In really a landmark study, it was determined that integrated multidisciplinary clinical care is superior to gastroenterologist care only in patients that are living with IBS. And so when we think about that integrated team, it combines the importance of a definitive diagnosis by a gastroenterologist or physician. And oftentimes it may include a treatment that starts with pharmacological care. So a medication, making sure again that they've had an appropriate workup. The diagnosis is delivered with a definitive diagnosis is delivered with hope to the patient. And then we start to look at what are their other needs. And it may be behavioral therapies, like what we're going to dive into today. It may be nutrition therapies guided by a registered GI dietitian. But some of the other important key members of the team can include the nursing staff to answer some of the questions in between visits, a social worker, a primary care physician, a pelvic floor physical therapist. All of these offering a dream team approach. And then here we have kind of the idea of a digital therapeutic potentially being added to the team. So let's take a step back, and a term that you may or may not be familiar with is the new way that we classify functional gastrointestinal disorders. The new terminology is that these are disorders of gut-brain interaction, thought to be a much better descriptor for what patients are experiencing when they have something like a DGBI, the most prevalent DGBI being Irritable Bowel Syndrome or IBS, but other DGBIs can be functional dyspepsia, functional upper GI conditions like dysphagia or globus. And when we looked at a survey study of 26 countries, we found a global prevalence of DGBI to be 40.3% of individuals met criteria for one DGBI. And of that group of individuals, 32, almost 33% had two DGBIs. So these are prevalent, these are bothersome, and also complex to treat. Understanding the gut-mind connection is a very good place to start when it comes to creating a treatment plan, creating buy-in into understanding their diagnosis, and therefore why we tend to make the recommendations of this dream team approach that includes many subspecialists. So helping a patient understand that the brain and the gut are constantly communicating in this bidirectional pathway, and that this brain-gut axis or brain-gut communication plays a deep role in both the experience of symptoms as well as the severity of symptoms. So symptoms are very real, and they are driven by what happens between the gut and the brain to the gut along what's called the brain-gut axis. So this picture can be helpful to begin to explain to a patient why sometimes medication alone isn't necessarily solving their problems, and also just how powerful the brain is. So unfortunately, many patients with IBS have gotten that kind of patient journey experience where it's just IBS, good luck. In the worst case scenarios, they've been told it's in their head. And if you've ever worked with a patient that has had that experience, in some cases that can be very traumatic. It can make them very weary of trusting their medical providers with treatment suggestions. So if we reel it back to helping them understand that these symptoms are very real, that your head is involved because of the power of the brain, but that it's a very strong interaction that happens between our brain-gut axis that can very much drive some of the IBS type symptoms that a patient may experience. And so describing that the central nervous system and the enteric nervous system are connected along our vagus nerve, which is driven by or runs along our brain-gut axis, and that these systems are constantly communicating. And 95% of serotonin is produced in our gut, and this can influence our mood and our bowel function. And then cortisol is another hormone that can be produced that affects our gut motility. And so our brain's influence can impact how fast or how slow our motility happens, secretions in the gut, how our microbiome is balanced, as well as our immune function. So this really starts to validate the brain-gut axis and the impact of our brain-gut system. And then there are other factors that complicate this. So how food impacts our gut, our intestinal permeability, the hypervigilance and hypersensitivity of the nerve endings in the digestive system. alterations in our microbiota that we know are true of patients that are living in with IBS, and then the different psychological comorbidities. So all of these functions and contributors affect our brain-gut interactions and the experience of IBS symptoms. Now, when you're in clinic with patients, this is also, I think, a very interesting statistic where 1 in 5 people with IBS, they don't want to discuss their symptoms with their provider. And so depending on their reason for showing up in your clinic, you may need to kind of bring up some of the symptoms and especially how they are managing and do they feel like they are just going to have to live with their IBS symptoms for the rest of their life, or sometimes education on the variety of other types of treatment that are available can be very helpful. So I think the commonality that we see in patients with IBS, they've been given a medication. Maybe they get a little bit of relief and it's better than what it was. And they either stop communicating with their provider or they kind of just live with it. And so asking your follow-up questions and follow-up appointments about how is their quality of life? Where is their bowel function at? Are they avoiding things because they still have symptoms? Then introducing some of our other options, potentially like a digital behavioral therapeutic, can really open the door to increased benefit and alleviation of symptoms. So when we think about psychological comorbidities, we do know that patients living with IBS have increased prevalence rates of anxiety and depression compared to the general population. And if the anxiety and depression is undertreated, this can worsen IBS type symptoms. So very important to be assessing for psychological comorbidities in this patient population. And I'll give you some guidelines on what to do in terms of treatment recommendations, given what the triggers for the mood symptoms are and any other types of psychological comorbidities. So before I dive too far into brain gut therapies, the psychological considerations really that we need to identify are coming from the perspective that if a person continues to have untreated psychiatric conditions that are moderate to severe, our brain gut behavioral therapies will not be as effective. And so kind of the red light in terms of making a recommendation for working with somebody like myself, a GI psychologist, would be any severe psychopathology. The patient shows very little insight into the gut-brain connection. They're overly focused on a cure. They're actively potentially using substances. They have untreated, unresolved trauma, any psychosis, really where their needs require a higher level of care. We want to prioritize those patients to the appropriate mental health provider or psychiatrist. Potentially appropriate patients are those that may be engaging in some disordered eating. We see this commonly in our IBS patients. So an example would be, avoiding food throughout the day because the food causes symptoms and they want to be able to get to work or school. So then they come home and that's when they eat. We can likely work with those types of patients to develop different nutrition and behavioral strategies to improve their eating. But if somebody has more of a full-blown eating disorder, then we would again want to prioritize those patients to an eating disorder specialist. We would assess for post-traumatic stress. We're looking at motivation, and really kind of the difference between a red light and a green light is going to be both the provider's comfort level with the presentation of the patient, as well as the motivation and insight of the patient to utilize brain gut behavioral therapies. And finally, our green light patients. Those are patients that understand and accept their diagnosis. They understand the role of a multidisciplinary team. They're interested and able to invest the time in the behavioral changes that are necessary and coping strategies. And they're really looking for an improvement in their ability to manage and kind of improve their quality of life through psychological and behavioral therapies. So working with somebody like me, my role is really to begin with this understanding that how we think, how we feel, and how we behave impacts what happens between our brain and our gut. It impacts our overall health and well-being. We will do an initial psychological consultation to kind of discuss the patient's overall physical, mental health, social history, and develop a treatment plan, and then implement the behavioral therapies that I'm about to share. So these are the kind of evidence-based brain gut behavioral therapies that are talked about in the literature. We have some self-management programs that could include, increased psychoeducation through books, self-guided readings, digital behavioral therapeutics, many different ways to highlight lifestyle strategies that can be sustained over the lifespan and improve a patient's kind of overall health and well-being, which trickles down to affect their IBS management. We have GI-specific cognitive behavioral therapy, gut-directed hypnotherapy, and mindfulness-based interventions. I always love to show this data because it used to be that, working with a GI psychologist was like, nothing else has worked with catastrophic thoughts. So a big one with IBS is that dreaded fear that what if I had an accident in public? Or and what if that happens, I'll avoid that by just not going out into public very much. And then with those avoidant behaviors, we develop even further cognitive inflexibility. And so many of these targets are ways in which we help patients to develop more flexible thinking, to identify their maladaptive cognitive processes, and work through the way in which our thinking can impact how our body is experiencing symptoms. Visceral anxiety is a type of anxiety that is driven by sensations that we feel in our bodies. So patients that have IBS have a higher degree of visceral anxiety. And then that hypervigilance is where you may feel a somewhat benign experience in the gut. So let's say you have lunch after, maybe many of you are eating lunch, depending on your time zone today. But after we eat, as the digestive process is taking place, you're going to feel some gurgles and cramps and spasms that can happen in the gut. For patients that are living with IBS, those sensations send those signals up to the brain. The brain kind of, the signals from the gut say, hey, did you feel that? The brain says, I absolutely feel that. And that could be really bad for us. And we have this kind of amplified pain sensation, symptom sensation that's hypervigilance. So the brain of somebody living with IBS has a harder time down-regulating those benign gut sensations. And we can really help through teaching different relaxation strategies, as well as CBT strategies to help with that control and normalization of the gut-brain function. So let's start also to dive into gut-directed hypnotherapy. So this has a very long history, with the first randomized control trial being published back in 1984. And so over the last 40 years or so, many additional research has supported the use of hypnosis for IBS, has the most research, but we've also done research in functional chest pain, dyspepsia, inflammatory bowel disease, abdominal pain in the pediatric patient population, as well as in heartburn. So what we can see here is that over the course of time with the therapy, these are science-based, science-backed interventions that can be helpful for patients that maybe have not had success with other treatments. It really starts to build their confidence, as well as hope there's something else that they can try. And gut-directed hypnosis can really work at that control and normalization of that brain gut communication. And that experience for patients is really profound. And also, we like to open up the conversation about hypnosis, because I think a lot of times patients are like, hypnosis, I don't want to be out of control. I don't want to cluck like a chicken when a bell goes off. What is this like? What is this going to be like? So I'll describe for patients that it can feel very similar to guided meditation or guided relaxation that maybe you've received in other types of therapies or by using other more general meditative applications out there. There are many. And the experience of hypnosis is you sit in a chair or lie down, your eyes will be closed, and we use very key sensory experiences and suggestions to talk to the subconscious brain about reminding it, hey, you know what to do during the digestive process. You know what not to focus on, and you know what to do in terms of going through the digestive experience. And so we'll use visual imagery to create a nice, peaceful scene. We'll then use auditory experiences. So for example, if we're thinking about a beach scene, I'll describe what the sound of the waves in the background, or birds in the background, or people laughing in the distance. And tying that also then with kinetic feelings and sensations. So while a patient is sitting in the comfort of their own home, I'm having them think about what it might feel like to walk on hot sand down to the water, where then it shifts to a cool sensation, and then the cooling sensation of gentle waves washing around their ankles. And so when we go through this experience with the patient over the course of about anywhere from 10 minutes to 30 minutes, they are really deeply relaxed and also very focused on the suggestions that we're giving from a therapeutic perspective. So when it comes to hypnotherapy for IBS, research has shown that as long as the patient, again, isn't experiencing psychosis or any psychiatric comorbidities that require more comprehensive care, if the patient is open and motivated to try hypnosis, that's actually more important than the characteristic of how hypnotizable they may be. And in fact, in my clinical practice, I don't even look at hypnotizability, though it is certainly a characteristic that we can assess for. Patients that are really good candidates for hypnosis really have that understanding of hypervigilance and that visceral hypersensitivity that they experience that worsens their symptoms. And they have that insight that stress can certainly worsen those symptoms. These are going to be patients that we're looking for when it comes to opening the door for suggesting gut-directed hypnosis. And as I've already mentioned, untreated trauma, psychosis, active eating disorders, we're probably going to do a bit more of a thorough psychiatric assessment to make sure that we're making these recommendations most appropriate for that patient. So I think there's been some very exciting research coming out of some of the researchers with Nerva and Mindset Health. And this was really a pivotal study back in, really it just came out in 2025, but some of this data was shared at the end of last year. So when we look at types of hypnotherapy that I do in my clinical practice, which is one-to-one. And then also looking at, is an app just as good, or does an app perform as well? And overwhelmingly, the reality for the appropriate patient is that yes, the app demonstrates overall improvements in symptoms, reducing abdominal pain, and improving quality of life. And what I'd like to highlight for patients living with IBS is that, unfortunately, I can't cure your IBS. That's an unrealistic goal. But what our job is in brain gut behavioral therapies, and really from this dream team approach, is that we're going to reduce the severity, the frequency, and the duration of when you experience symptoms. And also, really key in doing all of that is that you're confident that you have tools and strategies that you can implement and utilize when you do have kind of some fluctuations in your bowel habits. And that speaks to when people have GI symptoms, it tends to really skyrocket that anxiety because they've had negative experiences in the past. And so by going through and having a well-rounded toolbox that might include learning how to do gut-directed hypnosis, it really improves patients' confidence. And we do tend to then see the flare-ups really reducing over time. As I mentioned before, for patients that have a history of eating disorder, when we think about some of the most evidence-based strategies for IBS, we think of nutrition and we think about behavioral health. The low FODMAP diet for patients with IBS is an evidence-based type of nutrition therapy that can be very effective for patients. However, it's a restrictive diet. And so any patient that has a history of an eating disorder or disordered eating, we want to be very thoughtful before we would place them on a restrictive diet. And so this study that came out many years ago, but one that I still like to reference regularly, was a randomized controlled trial done by Dr. Simone Peters, which really highlighted the gut-directed hypnotherapy versus low FODMAP diet outcomes. And while they were basically equivalent in terms of quality of life improving across both groups, not surprisingly, the brain gut behavioral therapy improved the psychological indices. But I think most importantly, for those patients where we want to take the focus off of a restrictive diet or eating practice, I would really consider use of hypnotherapy before even going the nutritional route in many patients. So in these last couple of slides, I'm going to talk again, just highlighting a decision-making tool that you're going to have access to. And so I'm going to talk through this, but you'll have a beautiful visual that you'll be able to have access to shortly after our presentation today. So what you'll do is kind of working through this decision-making tool by asking, is IBS the primary driver? That's what we really want to find. And so some of the questions that you might look for are, are there comorbid GI conditions? So for example, if the patient is really suffering with IBS and also GERD, or maybe they have inflammatory bowel disease that's well controlled, but they also have some overlapping IBS symptoms, we want to work through that decision-making tree. If they have irritable or if they have inflammatory bowel disease that is not well controlled, we really want to make sure that that patient is receiving the appropriate medical care for their IBD before considering something like Nerva for that functional bowel overlap. Does the patient have moderate to severe anxiety or mood symptoms? And again, if the answer to that is yes, we want to get them appropriate psychological care. And sometimes concurrently, introducing Nerva could be of benefit. So we want to keep that in mind. Again, does the patient have active or unresolved trauma symptoms? Trauma rates are increased in our GI patient population. So number one, assessing for trauma is so important to ensure that a patient is feeling comfortable in their gastroenterology care. But if you are the first person that may be identifying the impact of trauma on a patient's life, making sure that we're making good, appropriate psychological referrals to a trauma-informed mental health provider is going to be very important for this patient. And then finally, as we've already discussed, if a patient has a history of disordered eating, this doesn't preclude them from participating in Nerva, but we want to assess where they're at. And in some patients that are working on a disordered eating plan, sometimes Nerva can be a very nice complement to kind of working to start to decrease some of that brain gut dysregulation while they're also receiving their eating disorder care. I wanted to provide some just additional thoughts when it comes to psychological assessment, which can help inform your decision tool making resources. Being mindful that, number one, that comorbidity of psychological symptoms is very high in our patient populations with IBS. So routine screening measures for anxiety, depression can be helpful to kind of take a look at before your clinic visits and see where the patient is at. being prepared to work with your psychiatry colleagues for those patients that may need more comprehensive care and maybe medication management, having a list of referral options for trauma-informed mental health providers on hand can be very helpful. And same with eating disorder specialists, which I do admit this is still access to good eating disorder care remains something that we need to work on in our communities. But knowing who is available so that you have resources for your patients can be very helpful. So moving forward in assessing for motivation and commitment. So again, thinking that the patients that are open and excited about trying something from a brain gut behavioral perspective, awesome. We really, those patients are likely to have good outcomes. But to help assess, again, which patients are best for this program, you want to think about, does the patient indicate that they understand and are interested in using behavioral therapies? It is an active participatory type of therapy. So the patient is both learning, they're receiving psychoeducation, and then they're applying many of these strategies. And so if a patient doesn't necessarily, they're not there yet, that you might want to have further conversations about the complexity of the diagnosis, the complexity of our brain gut communication, and help build some of the actions that maybe are outside of the box for them. Working with a psychologist to address their gut health may not necessarily, or maybe a new concept for them. Getting back to kind of patient requirements for Nerva, the last couple concepts that we want to just be mindful of is that the patient should have at least an 8th grade reading level, that they have access to a smartphone, so they've got good, strong internet availabilities, and that there can be there is a financial commitment on the side of the patient. And so I like to highlight that it's a very good investment for self. We invest in supplements, we invest in medical appointments. And so framing it from this perspective of really investing in yourself to learn key brain gut strategies from an evidence-based perspective can kind of help overcome some of the financial commitment for some patients. So this is really key. When you're introducing something like Nerva, digital behavioral therapeutic, again, you want to think that this may be a new concept for a patient. And so I like to use language that says, I'm going to remain a part of your care as the medical provider. But along with that, there are some strategies that can be very beneficial. And so the script might be one that you could practice. It's always great to kind of have a little bit of an elevator pitch. But what I really want to kind of highlight is that you want to make the recommendation for something like Nerva and then follow it up with, I'm not going anywhere, and I look forward to discussing how this treatment is going. So you really want to open the door, answer any questions the patient may have, highlight that this is an evidence-based strategy that's very effective for many patients with IBS, and that you look forward to getting their feedback along the way. So in summary, IBS management from a multidisciplinary care is important. It's available, it's safe and effective. And given, as I've shared, I do hypnosis with my patients on a day-to-day basis. I do think that Nerva offers a very strong option for patients that are motivated. They understand that stress impacts their symptoms. They're not suffering any significant psychopathology or have any of the contraindications that I've mentioned earlier. And so as we work to increase access to these effective brain gut behavioral therapies, this can be a very scalable solution for your practices. And again, we really are looking forward to allowing you to understand the benefits of our brain gut behavioral therapies and gut-directed hypnosis. So I believe with that, we will open up the questions, answer anything that maybe I've sparked some curiosity about.
Awesome. Thank you so much, Megan. As always, that was wonderful. And I will just hop in to let everyone know, and Megan, you mentioned it, but the clinical decision-making matrix that you went through, we will be sending out in a PDF format as well. It's a new tool we've developed with the help of Megan to help you sort of go through that exact decision-making tree with patients to make sure they are a good fit. If there is any questions, you can pop them in the chat, but I'll get started with a few. Is there any specific psychological traits, such as anxiety or catastrophizing that you mentioned, that predict a stronger response from gut-directed hypnotherapy?
Obviously, on the severe end, so any patients that are far more in need of more comprehensive mental health care, those patients are going to respond less to our brain gut behavioral therapies that include hypnosis. But in terms of even IBS subtype or being male or female, there really is a wide range of response. So I guess I like to highlight that it doesn't matter what type of IBS you have, whether it's constipation, diarrhea, fluctuating mixed, the types of protocols that we use don't change. So in terms of catastrophizing, my patients that might have higher levels of anxiety, the beauty of a one-to-one clinician is that I'll probably incorporate hypnosis, but also be doing some CBT work. And so I guess as a clinician thinking about our decision-making tools, if your patient's high level of anxiety, a lot of catastrophizing, a lot of avoidant behaviors, I would also like to see them receiving some forms of cognitive behavioral therapy to give them some additional strategies. Whereas the hypnosis can kind of calm things down, but you want to have some additional cognitive strategies in place too.
Awesome. A question from the chat here. How do you, if at all, modify the CBT and hypnosis protocols to meet the needs of patients who don't feel they do best with hypnosis or a CBT approach, but do well with an ACT and mindfulness modality?
Okay, so again, in one-to-one therapy, I'm incorporating a lot of these kind of third wave types of therapies. So ACT is acceptance and commitment-based therapy. Mindfulness, the key concept around mindfulness is, being non-judgmental about the present moment. And so that moment may be a pleasant one, that may be an unpleasant one. And so we use different mindfulness-based strategies to help patients build their resilience and an ability to cope with that mindful moment. And so I create treatment plans based on, my initial consultation with the patient to really assess, do they need some cognitive strategies from a CBT perspective? In acceptance and commitment-based therapy, you still utilize some cognitive reframing. And one of my favorites from an ACT perspective is this idea that, when we're cognitive reframing with CBT, we're asking, is my thinking helpful? Is it accurate? And sometimes the accuracy of our thoughts is pretty on point. But from an ACT perspective, it's how helpful is it? And kind of leaning into finding ways of thinking that would help us to improve our coping and strategies from an IBS management perspective. So certainly there has been research in using ACT and different mindfulness-based strategies as well in the IBS patient population.
Awesome. Another question from the chat here. Can gut-brain hypnotherapy or Nerva be used for other functional disorders? Or are the scripts currently IBS specific? I can answer this one. The scripts are currently IBS specific. So the protocol speaks specifically about lower GI symptoms, and as well as all the psychoeducation is specific to IBS. There is a lot of patients and providers that refer it to their patients with comorbid, other comorbid DGBIs, but just being aware of the fact that right now all the education speaks specifically about IBS. So it's most appropriate for IBS patients. Another question here, how do you determine if a patient's symptoms are centrally mediated versus primarily driven by gut physiology? And does that matter when making a recommendation to something like gut-directed hypnotherapy?
So I think this question is getting, I think it highlights the importance of a definitive diagnosis from a medical provider. And also asking patients to describe their symptom experience can be very beneficial as well. And patients understand realities of what visceral hypersensitivity is. I think it validates their pain experience, that your pain is real, but that it's nerve specific. And so we can't test for that necessarily, or at least it's not going to show up on a CAT scan or an MRI or in a colonoscopy. But understanding that nerve sensitivity is real, and one in which can be modified with a variety of different treatments that can be brain gut behavioral therapy. It could be a neuromodulator. Some of the other symptoms, like from a motility perspective, where we might use different types of medication based on how their symptoms are presenting. That's where talking more with your gastroenterologist from a medication management perspective around the anatomy of how stool or food may be going through your system really requires that team approach.
Maybe off the back of that question, you could speak a little bit to patients that come to you and really describe having more food triggers versus recognizing, more psychological triggers, and how with those patients you make the recommendation for a brain gut behavioral therapy. Is it more effective in patients that recognize the psychological triggers?
With nutrition, this is a big one. The reality here is we all have to eat. A patient with IBS, you're hard pressed to find people that don't have any connection between their food and their symptoms. Some people are able to make mild modifications in food. Others are making vast changes in terms of their nutrition. And so I guess that is part of the early conversation is, am I comfortable by maybe teaching them some relaxation strategies, talking about how if we're really anxious before we eat, that's going to impact our serotonin production. It's going to activate that sympathetic arousal and make the whole digestive process a bit more difficult. And so if we can use things like diaphragmatic breathing or some muscle relaxation or some hypnosis to kind of calm that down and introduce going into meals with a little bit more relaxation, that might help from a nutrition standpoint. But a lot of times, if somebody has made many significant reductions in both this kind of what they're eating, how they're eating, when they're eating, I often like to tag team that with a dietitian to maybe re-enter it, like start with a gentle diet cleanup, increasing the diversity of what they're eating. I'm working on the side of like recognizing this is anxiety provoking. And so it really is common, but also very individualized to the patient in terms of what their needs from providers may be to make sure that they're having a healthy relationship with food and that we're navigating the very normal anxiety that can go along with, food causes pain or food causes symptoms.
Awesome. There's a couple questions here around IBS subtypes and, is it as effective for all subtypes, or is there, more effective for IBS-D versus IBS-C? And a question around, is it tailored to different subtypes? Are the scripts tailored to different subtypes? I can answer from the Nerva perspective, but then I'll hand it to you, Megan. So Nerva, the scripts are not tailored to different subtypes. They are appropriate for all subtypes. And from the Nerva data, we don't see a difference in outcomes across subtypes, but maybe I'll hand it to you, Megan, to explain why that is.
Yeah, my answer is the same for the other protocols that are available. We don't tailor based on subtype. And similarly, data is equally effective.
Awesome. Final question here, and then we'll wrap up. Can you give a good resource to find clinicians that offer in-person gut-directed hypnotherapy? Obviously, Nerva is a great digital solution, but there is patients that might benefit from seeing someone in person. Can you give any resources for that?
Yeah, so a more global option would be through the Rome Foundation. They have a directory of mental health clinicians, most of which would be vetted and trained in gut-directed hypnotherapy. The Rome Foundation Gastro Psych group, if you Google that, you can find a therapist finder directory. And as I said, there are providers around the world. It's still limited, but that's probably the best place from the perspective of finding somebody that is very well trained. If you're in the United States, there's a group practice called GI Psychology that have trained providers across this in every state. And so they've really increased the access to GI mental health providers by offering virtual one-to-one therapy, as well as they have some wonderful groups and workshops that can also be a great option for patients really learning about the brain-gut connection and the variety of different strategies that are available.
Awesome. Thank you so much. We will wrap up here. So thank you so much. Thank you, Megan. As always, it's so wonderful to have you